Good morning. Today we have a discussion on femoral hernia, and we will discuss also the laparoscopic repair of hernia steps. Dr. Aaron Jyoti, who is a third year junior resident at MR Bangalore will present, and Dr. Sarfraz J. Beg from Bellevue Clinic will take us through the scenario. And I request Jyoti to please share your screen and present the case.
Good morning, sir.
Good morning. Good morning.
So, shall I start?
Yeah, please.
Myself, Dr. Jyoti, I'm going to present the case on Miss X, Latvia lady, resident of Soliganji, housewife, came to the hospital with chief complaint of swelling in right groin for 1 year. History of present illness: patient was apparently normal 1 year back, and present illness started as swelling in right groin 1 year back, which is incidence in onset, gradually progressive, and attains the present size, and swelling appears on standing, walking, and disappears on lying down position. And swelling is associated with mild, intermittent, dilating pain. No history of any other swellings in the body, no history of trauma, fever, no history of any bowel and bladder symptoms, no history of chronic cough, breathlessness, abdominal distension. Past history: no history of similar complaints in the past, no history of prior surgeries, not known diabetic, hypertensive, asthma, and tuberculosis. Personal history: takes mixed diet, sleep and appetite are normal, bowel and bladder habits are normal, married, 2 children, healthy, no habitual addictions. Family history not significant, treatment history not significant, allergic history not significant. Coming to the summary of the history: that fair lady presented with swelling in right groin for 1 year, which is gradually progressive and appears on standing and walking, and disappears on lying down position, associated with mild pain without any bowel and bladder symptoms.
Okay.
All right.
General examination. Yes. Patient is conscious, coherent, cooperative, well-oriented, time, place person. Karnowski performance status 90, height 156 centimeters, weight 56 kg, BMI 23. No pallor, no ectras, no cyanosis, no clubbing, no generalized lymphadenopathy, no periodema, no engorged veins. Vital signs: pulse rate 82 per minute, regular rhythm in right radial artery, blood pressure 130/18 of Hg in right upper limb, respiratory rate 14 per minute, regular, temperature 98.53 Fahrenheit. Coming to local examination: after taking consent with adequate exposure, patient is examined in standing and supine position. An inspection: a globular swelling of size approximately 3 into 2 centimeters is situated in the right groin with well-defined margins. Surface appears to be smooth, and skin of the swelling is normal. Cough impulse is present, and the swelling is reducible on lying down position. No other visible swellings are seen. Other hernial orifices are normal. External genitalia are normal. On palpation, no local rise of temperature, non-tender, and a globular swelling of size 3 into 2 centimeters situated below and lateral the pubic tubercle on right side below the inguinal ligament with well-defined margins, smooth surface, and foaming consistency. Expansor cough impulse present over the swelling, and external genitalia normal. Other hernial orifices are normal. Percussion dullness over the swelling, and distal examination normal to no growth palpable. Coming to systemic examination and abdominal examination,
No.
not significant, and abdominal mother tone are good. Other systems are normal. Coming to summary of the case: 35-year-old lady presented with swelling in the right groin for 1 year, gradually progressing, which appears on standing, walking, and disappears on lying down position, associated with mild pain without any bowel and bladder symptoms. On examination, gender survey is normal. Globular swelling is situated below and lateral to pubic tubercle in right groin with well-defined margins and reducible on lying down position, and expand cough impulse is present over the swelling. Systemic examination is normal. My provisional diagnosis is case of 35-year lady with right side femoral hernia without complication.
Right. So, Jyoti, very good presentation. Very nice. Tell me, what are the points in favor of a hernia from your presentation?
So swelling is gradually increasing in size, and it is appearing on standing and straining, and it is relieving them by taking rest on lying down position.
Right. And from your clinical
An examination, expansor cough impulse is present in the over the swelling, and it is reducible.
Okay. So you did not mention, I don't remember, you said effects of pressure on the lump, which means whether it reduced, where did it reduce? Did it reduce with a gurgle? Was it difficult to reduce? Do you think this is important?
Yes, sir. To know the content, it is important, and whether it is reducing either spontaneously or with minimal pressure we have to give.
Yeah. So I think you missed the reducible part, isn't it? The test. Okay. And why do you think this is a femoral hernia from your presentation?
So on examination, patient said in the right, on history, patient said patient is having swelling in the right groin. And on examination part, it is situated below and lateral to the pubic tubercle and below the inguinal ligament. So,
Right. Now, tell me, what is the typical age group, gender for a femoral hernia?
usually elderly female patients are more prone to the femoral hernia.
And which side it is more common?
Right is more common to left side.
Okay. Any reason?
So,
Do you know the reason why it is more common in the right? Proposed reason? Okay. So the processus vaginalis, disappears faster, and number two, sigmoid colon, which is loaded, protects the left groin. So that is a proposed reason for it. What is your plan for this patient?
so I want to investigate the patient and I want to proceed.
Yes.
What,
So what
you
is
need
the
admission for diagnosis?
Surgical.
Okay, so surgical. Is there any role for medical management?
No, sir.
Why?
So as femoral hernia more prone for complications. So, yeah.
So as opposed to a inguinal hernia, femoral hernia has about a 20% chance of strangulation. Therefore, there is no role for medical treatment. It is recommended that we do surgical therapy. Okay. What are the boundaries of the femoral hernia?
Anteriorly is by the inguinal ligament and medially by the lacunar ligament and posteriorly by the Cooper's ligament and the pectineus, fascia covering the pectineus and Cooper's ligament, and medially it's the septum separating the lateral septum separating the femoral vein.
Okay, good. So let us say you investigated this patient and you are now planning for a treatment. What approach will you take for the surgery? What is recommended?
Inguinal approach.
Between open versus minimal access, which is preferable?
Female patient and you have a femoral hernia. So now that actually the recommendation is changing. You see, now the indication for laparoscopic hernia is now more extended. So you can easily say that we will go by minimal access approach. Okay.
So minimal access approach is the preferred treatment. And why is that, Dr. Jyoti? Why? What is the advantage of minimal access preperitoneal approach over open approach?
So faster recovery and early discharge to the patient, and compared to pain.
And some patient may have an associated other hernias that you can diagnose.
Yeah. So femoral hernia in females usually have a 50% association with groin hernia, whereas 10% of femoral hernias, 50% of femoral hernias in men are associated with groin hernia. Then 10% of femoral hernias in women are associated with groin hernia. So you can imagine how the myopectineal orifice weakness is more generalized. So a femoral hernia is a surrogate marker of a myopectineal orifice weakness. So if you see a femoral hernia, one has to do a complete repair, and the complete repair of the MPO or myopectineal orifice is best possible with a laparoscopic preperitoneal approach, endoscopic or laparoscopic preperitoneal approach. Okay, so that you do not miss any other concomitant hernia. Okay.
Myopectineal orifice boundary.
Myopectineal orifice boundary. Repeat.
Medially, it is by the lateral border of rectus abdominis, and laterally by the iliopsoas, above by the conjoint tendon, and below by the pecten pubis. All the hernias of the groin and comes through.
Right. Okay. Makonda, you start taking questions. আমি হাত ধুচ্ছি, আমি এটা হাতে রাখবো।
Okay.
আমি আছি, আমি শুধু ভিডিওটা অফ করছি,
Fine.
অডিও আছে। You keep
So
on
you said
questions.
the management in this patient will be operating. Okay, and you said you investigate. What investigation you like to do for the management of this patient?
Sir, to rule out other hernias also, and occult hernias with the USG groin region, and for the fitness of the patient.
Because it is very difficult to diagnose occult hernia by doing USG. So for hernia diagnosis, it's a clinical diagnosis. Once you have a diagnosis of femoral hernia, you need not do ultrasound to diagnose patients as hernia or not. So it should be your clinical diagnosis. And as I say, if you want to go for a minimal access approach, you can see on laparoscopy whether you need. So a USG is a clinical examination. You can do that, but idea is not to diagnose the occult hernia. It's difficult to diagnose occult hernia by ultrasound itself. Okay. So and then the remaining investigation will be based on what?
For confirmation of for fitness
For
for
a
surgery.
fitness. When you need some more special investigation if patient has got a hernia.
So if patient is having any chronic straining factors, so we have to.
So elderly lady, this lady might have some pelvic pathology. So it might need to do a ultrasound of abdomen. Patient has got a chronic straining factor. She does not have bowel or bladder symptoms. If the patient has got chronic straining factors causing micturition, you need to exclude any ureter obstruction. So ultrasound of the QB. Okay, patient has got some bowel symptoms. A hernia may be manifestation of a underlying chronic carcinoma. So if you have some symptoms that suggestion, you should investigate in that light. Patient may have some chronic straining factors in the form of chronic bronchial asthma. We might need to do a pulmonary function. So these are not routine tests. This test will be done based on your history and examination. If the patient has got associated comorbidity, you have to do these investigations. Okay. So femoral hernia, you said, is occurring through the Hasselbalch triangle and then exit through the femoral ring.
Fine.
And then it comes to the femoral sheath and comes to the saphenous open. Okay. And the myopiclar orifice, you said the boundary is the area through which all the groin hernia comes. Suppose you dissect the femoral hernial sac and push it. Where does it go?
It goes into the Hasselbalch.
Yes. So you have to keep in mind that a hernia which is coming up in the Hasselbalch triangle, if it takes exit through the subocerebellar ring, it becomes a direct hernia. If this bulge in the Hasselbalch triangle takes exit the femoral ring, it becomes a femoral hernia. So how do you classify by EHS system?
So primary or recurrent.
Yes. So this is a primary hernia here. There is no history of operation. And second is
lateral, medial, femoral.
So medial is direct, lateral is indirect, F is
femoral.
And then how do you assess the width?
0 and X and.
So that is by finger, by centimeter. So that is the way to classify it EHS. So we said you will do a minimal access approach. What are the minimal access approach for repair of groin hernia? Yes.
Total extraperitoneal repair and
the other one is interperitoneal only mesh placement is now not done. So these are the two important minimal access approach for groin hernia repair. So if you go by TAPP, describe the steps of TAPP repair from groin hernia. How do you go for, you see, if you have a femoral hernia or a inguinal hernia, the minimal access approach is almost same. You have to dissect a particular area, create a space, and there are some steps before you place the mesh. So what are the steps for coming on to the operative steps? What are the steps of TAPP repair for groin hernia?
patient under general anesthesia when endotracheal to the patient. And position, coming to position of the patient, initially the patient is supine, and after creation of pneumoperitoneum, we will change the position.
So you should talk about catheterization. While doing Groin hernia, you need to catheterize the patient because during surgery the patient gonna get full, it's difficult to dissect this area. So patient should be catheterized, and then general anesthesia. Position the patient is supine with head and down. If only unilateral hernia, that side of hernia, patient may have some elevation on that side. Tilt. Then
Creation of the pneumoperitoneum.
creation of pneumoperitoneum. Okay, either by open or closed. So you have created pneumoperitoneum. How do you keep the abdominal pressure?
So 12
Maybe 14 also. Okay, fine. Then
and
what are the landmarks? Once you take your scope into the abdominal cavity, what are the different landmarks in this area?
once we enter into the abdomen, we have to see the median umbilical ligament, median
So
umbilical ligament.
just one by one. The landmarks are important because you have to identify the landmarks before you proceed the TEP operation. The first thing you look at the midline. What is that?
Median umbilical ligament.
Formed by
The ureter.
formed by the urethus. So urethus raised a peritoneal fold, that is median umbilical ligament. And then if on either side, the next landmark is
Medial umbilical ligament.
which is formed by
Obliterated umbilical ligament.
okay. So umbilical raised a peritoneal fold, that is medial umbilical ligament. And then next is
The lateral umbilical ligaments were formed into the epigastric ligaments.
okay. So these are the three important landmarks you look at as you go with your scope. Three ligaments: median, medial, and the lateral umbilical ligament. What are the area in between the median umbilical ligament and the medial umbilical ligament? What is that area?
Supravesical.
Supravesical fossa. What is the area between the medial umbilical ligament and the lateral umbilical ligament?
Medial inguinal fossa.
Medial inguinal fossa. An area lateral to this.
Lateral inguinal fossa.
So these are the important areas where you should know and you should find where the hernial sac is bulging. Supravesical hernia occurs to the supravesical fossa. Medial inguinal fossa is the site for direct inguinal hernia, and lateral inguinal fossa is site for indirect hernia. And what is the normal appearance of the deep ring in a normal person? If you look at the deep ring, what do you find in the normal deep ring is? Normal deep ring is closed, and you find two important structures coming through this. What are these?
Hard structures and
Yes, the vas deferens and the testicular vessels. So in a normal person, as you take the scope, you will find that deep ring is closed, and you find the testicular vessels coming laterally, and then vas bulging going medially. That is the normal deep ring. Suppose he is a patient where you have gone in. Will you find the femoral hernia straight away on entering the peritoneal cavity? What? You see, try to understand. You will find the structures which are just seen interperitoneally. If it's a direct hernial bulge, you will find there's something bulging to the medial inguinal fossa. With the indirect hernia, you will find the deep ring is open, and the content is going to the deep ring lateral to the lateral umbilical ligament. But you will not find the femoral hernia as you take the scope to the deep ring. Now, what you have to do? Because you already diagnosed patient got femoral hernia.
you have to go deep to the
How? What do you do? Now then, you
submucous
did not find a medial hernia or lateral inguinal fossa hernia. It's not there. Now you have a diagnosis of femoral hernia. What you start doing now?
preperitoneal flap.
So yes, now you have to raise the peritoneal flap. Where do you raise the peritoneal flap?
Usually starts from lateral to the
Yes.
medial to the
So
base
find
of
the anterior superior spine. Okay. First thing is you have made a scope. That is one port. You need to place two more ports. The hernia is done through three ports. One 10 millimeter port in the subumbilical region and two 5 millimeter port. Why do you put this through?
right and left lower quadrant lateral to the rectus.
Yes. So you can place in the lower quadrant either side in the spine umbilical line. Okay. and you stand usually on the side opposite to the hernia. If it's bilateral, you can stand on any side. Okay, otherwise, if you are putting the right side, you should be standing on the left side of the patient. So, 3 ports are made. Now, the next step is what? So, the first step is creation of neoperitoneum, placement of first port, subumbilical port, is a blind port. You should go cautiously. Then placement of 2 more ports, 2 more 5mm port, and then visualize the area, delineate the anatomy, and then you have to proceed. What to do next?
So I have to raise the peritoneal flap and
Yes.
some like to,
Yes, just medial to the anterior spine. And if you take the deep breath, this peritoneal flap incision will come above the deep breath. And how far you go medial with the incision?
After medial umbilical.
Yes, don't go beyond that. This peritoneal incision on the peritoneal flap will be ending medially at the median umbilical ligament. If you go beyond that, you can injure the bladder. So, lateral to medial, the marking is made in the peritoneal cut. Once you made a small cut, what happens there? Carbon dioxide goes. You already have pneumoperitoneum. You made a small leak, the carbon dioxide goes into space. So some space is kept by the carbon dioxide. And then you take the flap and dissect the flap down. And as I say, we have not seen the femoral hernia sac yet. Now what you do?
Now I will go and wait.
Which dissection you will do now? You have incised the peritoneum. You are now going down.
Medial dissection.
What dissection you require to place the mesh and this the hernia sac?
Medial dissection and lateral dissection.
Yes. So you have to do a medial dissection, lateral dissection, and then this the hernia sac. If it is either a indirect hernia or direct hernia, whatever it comes. So once with the medial dissection, what do you find?
The medial dissection first I have identified Cooper's ligament.
Yes. So lighthouse. Once you bring this peritoneal flap down, you find the lighthouse. That is the bibigramus with the attached Cooper's ligament. So bring it down. Once you're going there, if it is a direct hernia, that is a site for direct hernia. As you are reflecting this peritoneal flap, if it is a direct hernial bulge, this peritoneal flap will bulge into the area medial to the medial umbilical ligament, area lateral to the median umbilical ligament. And then as you bring down, you will find there is a pseudocell. There is a bulging of the transversalis coming from the groin area. So you have to strip it towards the groin. And then as you come down, now you say the boundary of the femoral ring is anteriorly angular ligament, posteriorly Cooper's ligament. So as you bring this peritoneal flap down, now you can find the Cooper's ligament. And anteriorly find the inguinal ligament. So we will now find a bulge. You will now find a bulge of this peritoneal sac going to the femoral ring. And same like direct hernia, you may have a pseudocell. So dissect this hernial sac. Usually, as you say in examination, I forgot to mention, you don't percuss a femoral hernial sac. You listen to nothing. He said there is 3 centimeters swelling. So where do you percuss? And what do you say? So there is no role for percussion in a hernia which is about 2 or 3 centimeters in size. You cannot appreciate the note. It's difficult. So you now dissect the hernia sac. And how far you will dissect medially? Only previous impulses. Medially to go up to the rectopubic space, octave of radius. As you bring this flap down, you have find the Cooper's ligament. And ideally, as you place the mesh should overlap beyond the midline. So you reflect this and dissect up to the in the midline, this is the rectopubic space of radius. As you go laterally, what do you find? What do you find below the pubic ramus? Pubic ramus is there, where you find the Cooper's ligament. As you go down, you reflect the bladder, and that is the area of space of radius. As you go laterally, what do you find in the same space? Space of Bobros is the layer area between the two layers of lateral bursas. As you dissect into space, what do you find laterally? What is there below the pubic ramus? Obtruder foramen. So some patient may have an obtruder hernia. So if you keep on dissecting as you go laterally, you find the obtruder vessels and nerves going. So the limit of dissection is this: don't go below that. So dissect that area where you find the lower border of the pubic ramus. That is the area of obtruder hernia. Now you are referring to the lateral side. Where do you go in the lateral side? What do you reflect? As you pick up the peritoneal flap and start reflecting, what do you find? No, you are in the lateral to the deep ring. What structures you find as you keep on reflecting the peritoneal flap?
Now, lateral femoral cutaneous now, genital femoral.
You keep on lifting. What is coming up? If you look from the back, this is the anatomy you are looking from the intra-abdominal side. What is that structure which is running at the lower limit of the intra-abdominal wall? It contains the fibers and vessels from intestinal spine to the pubic tubercle. Iliac tract. Okay, this is the structure corresponding to the inguinal ligament anteriorly. If you are going from the back, you are looking at what? Transverse abdominis. And outside this is the fibers and vessels. As you reflect the flap, you find a condensed facet and vessels coming in the intestinal spine. That is iliac tract. And then you have to dissect further. How far? You have to find the myopic orifice of Fuchs. So as you reflect, you find the hilus fossa. So your lateral dissection should be up to the lateral part of hilus fossa. As you go now in the middle part. So medial part is Cooper's ligament, cave of radius, obtruder foramen. Lateral part is you raise the peritoneal flap, expose the iliac tract, dissect further, and expose the hilus fossa. And over the hilus fossa, you can find the genital femoral nerve. And now come to the middle part. If it is a femoral hernia, there will be no bulge the peritoneum to the deep ring or the direct hernial bulge. But you have to now reflect the peritoneum. How far? Understand? You have reflected the medial part of the peritoneum. You have reflected the lateral part of the peritoneum. Now the middle part is now stuck in the deep ring. Okay, this patient does not have a inner hernia. But this peritoneal flap now has to be reflected because you need a place for mesh placement. So how far you now lift?
In the divergence of the wall depends on the cartilage.
Yes. Though the limit of raising this flap in this part of the dissection is you should dissect taking care of the testicular vessel and the vas difference, and the point where the testicular vessels and the vas diverges. The vas goes medially and vessels goes laterally. So that is the area where you should raise the peritoneal flap. So that is the way of dissecting the femoral hernial sac. And same answer will apply. If you are doing a repair for direct hernia, you say that I will find the bulge medial to the lateral inguinal ligament, lateral umbilical cord. And as you dissect the bulge, the peritoneal bulge, as you dissect, you find the pseudosac. And pseudocus is still towards the groin. If it is inguinal hernia, you start dissecting the hernial sac from the cord structures. And always keep in mind that if you find this inguinal hernial sac is a complete one, that means the sac has gone on the bottom of the scrotum, you cannot take the fundus of the sac out. So if it is a complete inguinal hernial sac in indirect hernia, you dissect, separate from the cord structures, tie it proximally. tie the sac proximally, and then distally you divide the sac using an electrocautery and keep this distal end open. Don't try to dissect a complete inguinal hernia sac. And then lift this peritoneal flap proximally to the point where you find the vas and the short vessels are getting separated. So now you have created a space. What do you do next? What mesh? What is the size? You repeat it. Yeah, because the peritoneal flap is a pre-peritoneal mesh placement. A polypropylene mesh is good enough. Now you have another mesh available in the market that is known as an anatomical mesh. This mesh is a polypropylene mesh, but it is constructed such a way that if you see this area anatomy, we have an area which is atomic space, and beyond that it bulges like this in the deep ring area, and then again it bulges medially. So this anatomical mesh fits into this anatomical bulging. So you can just place the mesh. You may not require any fixation. When you are placing the mesh in the pre-peritoneal space, there are some people who do not fix it, but the recommendation is you should fix at least to the Cooper's ligament. So as you take a polypropylene mesh, the standard size polypropylene mesh is 15 by 12. 12 is the height, width, and length. Transversely will be 15. So take a 15 by 12 mesh, polypropylene mesh, and bring it in the pre-peritoneal space. The medial border of the mesh should go a little beyond the midline on the other side, and fix it with the Cooper's ligament and place the mesh laterally. You can take one or two fixation medially. Don't fix any tacker lateral to the DP because that is the area of nerves. Recurrent branch of femoral nerve, femoral nerve, lateral growth of thigh. So no fixation beyond the DP, lateral to the DP. You can fix one or two tacker or switcher middle to the DP. So once the mesh is fixed, what is next step?
Close the pre-peritoneal flap to raise.
Yes. So you close the peritoneal flap. How do you close that? Yes, either using a bicual switcher, and now you have another switcher available in the market is a wheel-up switcher. Where if you keep an hand while closing the peritoneal flap, you should keep in mind that you have to reduce the abdominal pressure. Bring the abdominal pressure down to 8. Because if you are keeping it bulge, it creates tension in the switcher line. So bring the pressure down to 8 mm of mercury and then close the flap in the waist by using either a bicual switcher or a burp switcher. What is the advantage of burp switcher? One is not pressure required. Second is, as you take the bite, as you pull each bite, then might get fixed. In a bicual switcher, as you apply, you should keep a traction on the thread, otherwise it gets loosened up. But burp switcher, as you take a bite and pull it, that burp switcher gets fixed up. You can release the switcher. So this is a pre-peritoneal repair. Describe the steps of TEPP repair. TEPP.
Patient is hypertensive and under general anesthesia of cranial tube intubation, and patient is supine. After Nemo will change the position to head down position, and first creation of the Nemo subumbilical port.
In TEP repair, don't clear a new operation. The approach is you have to enter. It's a totally extra peritoneal repair. So how do you start? How do you create the first port?
The first initial is subumbilical. We'll keep one subumbilical push in the midline.
In the midline? No. If you read carefully and see, it is not exactly midline. When you are doing a TEP repair, this incision is placed from midline to one side because you need to go onto the rectus sheath. You will not be operating on the linear one. So below the umbilicus, take incision of 1.5 centimeter from midline to one side of the abdominal wall. Then as you dissect, use a S retractor to separate the skin flap. And then what do you find? Anterior sheath. You made an incision.
And left is to be retracted later.
Yes. So you first make incision the anterior sheath. Pick up the flap of the cut anterior sheath. And using the retractor, you dissect the rectus muscle laterally. Now, using a long hemostatic forceps, you create a space between the rectus abdominis muscle anteriorly and the posterior sheath posteriorly. There are a lot of other ways to create this space, but now people are not using balloon or other things. You just can do the dissection by using a telescope. So just create a space between the rectus muscle anteriorly and the posterior rectus sheath, and then place a 10 mm proper. Connect this to the insufflator, taking high flow. You can take almost from the 20 liters flow. So as you place the dropper in the area between the rectus muscle anteriorly and the posterior rectus sheath, you connect the insufflator tube. As the commander side goes, is within the tissue plates. Now we go inside the telescope. What do you find? If you're in the right plane, you will find the floppy things. You will find the loose alveolar tissue plane. There will be minimal bleeding. And it is better to use a 0-degree telescope at this stage. So what is the next step? Now you have created the first port, connected this to a insufflator, and then you have taken a 0-degree telescope and then going in the plane, in the pre-peritoneal plane. What is the next step?
And placement of the subsequent portion.
You see, once you place the telescope, you cannot place a subsequent port. We have to dissect. The next step is telescopic dissection. Because the port placement will vary. There are two ways to place a port. Some people will operate putting both the ports in the midline. Other people will place port on the either side of the parietal area. So the first step after the placement of the dropper is telescopic dissection. You go in the midline, remaining in the correct tissue plane. As you go in the midline and start in the telescope, you find the lighthouse. That means first thing you have to find the superficial and the pibigrammas. Once you get the pibigrammas area, you dissect in the midline. If your intention is to place a midline port, you place one port just around the symphysis and another port in between this and the subumbilical port. So that is a operation you are doing in the midline. If you want to place lateral ports, you need further dissection. That means in the same telescope, you keep on dissecting in the pre-peritoneal space. On this side laterally, on this side laterally. And in the parietal space, you place a 5 mm port with maintaining the triangulation. So now you are in the pre-peritoneal space with a camera port and 2 lateral ports. How do you proceed next? What is that? Because it is same. What you have done TAPP has to be done in the TEP also now. So now you are directly in the extraperitoneal space with the camera port and 2 lateral ports. So first dissection will be here in TEP. You start with the middle dissection again. So as you are going into the pre-peritoneal space, already you have found the Cooper's ligament. If it is a direct hernial bulge, you will find the hernial sac is bulging above the Cooper's ligament. The direct hernia is above the Cooper's. So as you dissect the hernial sac, just above the Cooper's ligament, you will find the hernial sac is coming towards the abdominal cavity and the pseudosac will be stiffed outward. If it is an indirect hernia, you just create the medial space. The indirect hernia will be lateral to the into a strict vessel. So now you dissect the medial side. That means you dissect the Cooper's ligament area, go medially, dissect the retropubic space, and then go laterally up to the operators. Then you come to the lateral side. Here is the pepidurnal space. As you come to the lateral side, I keep on stripping, you will find the iliopubic tract. Further dissection will expose the psoas muscle. So medial dissection, Cooper's ligament, retropubic space. Lateral dissection, you keep on dissecting, find the iliopubic tract, find the ilial psoas. You can see the lateral south side. And on that psoas, you can find the femoral. Then if it is the indirect hernia, now you find that the hernial sac with the cord structures in the intervening area. And it is now covered by the cremasteric fascia. You have to incise this muscle there. Exactly in this area, if you go by TEP, even cremasteric fascia will not come. It will be internal spondylic fascia. Because cremasteric fascia comes in the inguinal canal beyond the internal oblique muscle. So here you find there will be no cremasteric bulky muscle. You will find there is a fine fascial layer covering this cord structure in the hernial sac, the internal spondylic fascia. So now you start dissecting the hernial sac on the cord structure. As I said, you find the fundus is there in the inguinal canal. You can dissect up to the fundus. But if you know beforehand is a complete hernial sac, don't try to dissect the hernial fundus, because it will be difficult. You cannot do that. So in that case, you create a space between the hernial sac and the cord structures, ligate proximally, and divide the distal end of the sac. And now again, you have to lift this pattern flap up to half hour. Again, vessels and the bulge difference divergence. This is known as patellization. That means this you create a space to place the mesh. Again, what mesh will not take for placement? Again, 15 by 12 mesh is adequate for our patient population. You place the mesh, and as you have gone to the pepidurnal space, if you can place the mesh comfortably and you deflate the abdomen, if the mesh stays, usually it does not get displaced. And at all, you require a fixation. You fix where? Cooper's ligament. You just fix it. And here you need not stir anything. You just deflate. And then you have to keep in mind that you have made a little longer incision. So you have to repair this fascial defect, the 10 millimeter. Okay. Dr. Safraj, you have discussed the operative steps.
I was listening to it while I was operating. I listened and I was impressed by the details that you were giving to them and the fact that they were imbibing all the details. Amazing, absolutely amazing. This is good enough for specialists also.
No. This is for only trainees.
No, very well.
So, any other question you like to ask?
Not a question. I would like to put in a suggestion that when you are asked about the operative steps of, let us say, TEP approach for groin hernia, I would like you to think about it point-wise, whether you say port creation,
yes,
that is one subumbilical, two midline ports or lateral ports. Then you say dissection of the retropubic space of Retzius.
Yeah.
Then you say space of Bogrow's dissection and identifying the nerves. Then you say sac dissection and separation from the cord vessels. And then you will say parietalization of the cord, which means you're separating the sac from the cord structures at least 5 centimeters in a small hernia and 7 centimeters in a large groin hernia inferiorly. And then we say place, once we are, there's something called there's a new concept called a critical view of myopectineal orifice. This is the critical view, the space of Retzius, space of Bogros, nerves identified and separate. You have an inferior flap dissection. you're not missing the lipoma of the cord. That is also part of the critical view of the myopathy case. Then you have dissected the femoral hernia space. Then you can see the vein in medially. This is a huge concept, but what I'm saying is, you from your point of view, say port placement, space of radius dissection, Bogro space dissection, looking at the SWAS, sac dissection, prioritization of the cord, putting in the mesh, fixation at the Coopers, 1 or 2 fixation, complete. So I want you to at least remember that when you go into the details, you may lose the bigger picture. Don't lose the bigger picture. That is your bigger picture. Okay, so that was what my suggestion would be for your exam purpose. All right. Yeah.
Yes. Complications. You have done a
Yes.
hernia repair, and then what will be the post-op complications?
Like,
Suppose you have done a TAPP repair.
can be general complications and the specific surgery. And specific surgery.
जोर से बोलो, सुनाई नहीं दे
हाँ, मेरे को सुनाई नहीं दे रहा है.
रहा.
So general complications are specific to surgery complications, and general complications patient may have the atelectasis and DVT type of complications. And coming to the surgery related, immediately patient may have acute pain, urinary retention.
No. You should keep in mind, if you are doing TAPP, we have all the intrinsic complications of neoperitoneum. You see, you are doing a blind neoperitoneum. So, neoperitoneum related complications. So, these are again general complications for any laparoscopic repair. Next is hernia related complications. We are going for the hernia repair. What are the specific complications in the hernia repair? Now,
So
what can happen?
pain, bleeding.
One is bleeding. That means bleeding and bleeding a postal hematoma. And then subsequently, what happened to the hematoma? Patient may come with seroma. Seroma is another important complication for laparoscopic repair. Then
Infection and
infection. And then
Chronic
again,
pain.
if it is a large hernia, actually with the gut or whatever, you may have gut injury, you may have bladder injury. So all complications can come. Okay. Suppose patient comes with seroma. Post-op you find patient got a bulge in the hernia area. How to manage seroma?
So if patient is having seroma, it is superficially placed, will drain it. Always nice if it is
What is the
large
management?
amount.
What is the management for seroma? Seroma is a common complication following groin hernia repair.
Single stitches will the more collection increase.
When patients come with seroma, what do you do with that? First, you have to reassure the patient that this is a connection, this can happen. And then, what happened to most of the seromas? To keep it follow up. Most of the seroma resolves spontaneously. Okay, but you have to exclude that seroma is not seroma, is a infected collection. Infection has to be drained. If it's simple seroma, you can keep on waiting, it may resolve. Or if you're not resolving large seroma, you can do aspiration. Okay. Anything else? What about chronic pain?
What about chronic pain, Dr. Jyoti?
So pain is
How do you define chronic pain following groin hernia repair?
pain lasting for more than 2 or 3 months.
Yeah. All right, that's controversial, but yeah, 6 months maybe. In any case, when you say chronic pain, remember in femoral hernia, chronic pain is seen very commonly, 15% compared to less than 5% in inguinal hernia repair. So a femoral hernia repair has a higher chronic groin pain incidence than a groin hernia repair. Why do you think that is happening? Because the nerves.
Why chronic pain?
To the,
What happens? You place the mesh and you're not suturing. You see, in open hernia, people say that you suture around the pubic buckle, there is periosteitis, there is some nerve compression. What happens in groin hernia repair because of a laparoscopic? You place the mesh. What happens?
Some due to fibrosis, now
Yes.
gets entered into the.
So, because of fibrosis, then the entrapment of the mesh. So, how are we going to practice this?
Patient is having initially will do with the conservative management with NSAIDs and the local blocks. Patient is on local blocks. So if it is not resolving and patient is on persistent pain, we can go with the.
There are many things described, but it's difficult to offer. Yes. Yeah, got a bit. Just few things about the chronic pain management.
Yeah. So I think a good way of saying this could be that there is a step ladder approach to management of chronic groin pain. We start with pre-operative counseling has already been done that this is a possibility. So reassurance is one. Then we try simple analgesics like NSAIDs and then opioids if necessary. If this does not work, then imaging is done to exclude other causes of chronic groin pain. Remember, chronic groin pain has many facets. Some people are sports people, they can have sports pain. Some people have other causes of chronic groin pain, like referred from the lumbosacral spine and is misinterpreted as a post hernia repair pain. So doing an imaging is step 2, excluding these causes. Then comes if this pain is indeed due to the hernia repair and is not responded to analgesics, patient should be referred to a pain clinic where they will employ some sort of nerve blocks. The nerve blocks will be targeted to ilioinguinal, iliohypogastric, lateral femoral cutaneous. So it will all depend on which nerve they are expecting. And this is done on the basis, the block of the nerve is done on the basis of something called a DMT, dermatomal mapping test. So dermatomal mapping test tells us whether we are dealing with a neuropathic pain or a generalized pain. For example, a generalized pain could be because of a chronic seroma. Generalized pain could be because of a chronic mesh infection. Whereas a neuropathic pain will be in the distribution of the nerve, right? For example, a pain going into the groin, into the scrotum on the medial side is probably an ilioinguinal, right? So we will need to do a DMT, a dermatomal mapping test, to know which nerve is involved and then block it. Finally, if the nerve blocks also do not work, imaging shows that this is indeed due to mesh entrapment. Then mesh excision with triple neurotomy is the the treatment of choice. But that is absolutely the final frontier, and it's a very hard task, very technically demanding surgery. Therefore, it should be reserved for absolutely the non responding cases. So this is
In
about
the exam, you
chronic
should be
pain.
able to say this approach. The approach is important. These are the recommended approach for chronic groin pain. Starting conservative, step ladder pattern, and then final, and the last is not manageable. There is a road for doing such surgery, but it's difficult.
I just took you through a little bit because this is an important short note, I think, nowadays. It's also an important question in the hernia field. Therefore, knowing about chronic pain is important. The other thing I wanted to add is when you are asked about outcomes or complications of hernia, although I also follow the same thing which you said, bleeding, general complications, local complications amongst the local bleeding, infection, injury, and recurrence. But in hernia world, nowadays, the classification of outcomes when in any journal, when they have to publish hernia, it will be SSO, SSI, recurrence, and chronic pain. So these will be your 4 outcome measures. Amongst SSO, you would have seroma, hematoma, mainly these 2. Whereas in SSI, there would be superficial and deep. And there's something called SSOPI. Now, in the next 5 years, I think SSOPI will become a far more important determinant or measure. SSOPI means surgical site occurrence requiring procedural intervention. So you having a seroma, but which responded on its own is unimportant outcome. But a seroma which required aspiration is a SSOPI, which is an important adverse outcome. Similarly, an infection which required nothing is a SSI, but if it requires an antibiotic, an intervention, surgical debridement, then that is important. So SSOPI will become an important measure. Also remember, SSO means both seroma, hematoma, infection, wound adhesions all together. So it's a little confusing when I say SSO and SSI separately. SSO includes the SSI based on the definition of EHS. So just few points out there, okay?
Yeah. Good enough. It should be, Dr. Safra has given a very good idea that any operation you describe should be in steps. Make a heading and give the description of that particular heading. Okay, you don't miss anything. So our thinking is closer. The way you describe. Okay.
No, but Dr. Jyoti
Safra,
presented very well. Very well, Makunda, and you gave a very exhaustive, detailed about the surgery. It was so impressive. I was operating, but I was listening to you carefully with intention. Thank you very much for including me in this program. It was wonderful. Thank you very much.
Thank you. Thank you. Thank you. Dr. Maiti, any comment?
Professor Saha and Dr. Sarfaraj. Actually, I could not follow the class because connection was not good. So it was discussed only the femoral or the groin hernia.
Only femoral. We have discussed the femoral hernia as a case, and then we discussed the laparoscopic repair of groin hernia, TAPP and TEP steps.
So did you discuss the open method of repair?
No, open method discussed separately. That was another operative scenario. We discussed Liechtenstein, but today we have kept laparoscopic repair of groin hernia, TAPP and TEP.
Or the femoral hernia.
Laparoscopic repair it's for groin hernia, because you find the sac differently. The approach is almost same. You have to dissect the whole space. In TAPP, you raise the flap with the peritoneum. TEP, go into the peritoneal space directly. So,
okay, Dr. Sarfaraj, can you tell something about the mesoma treatment of mesoma, the surgical outcome of the treatment of surgical intervention for the mesoma for the groin hernias? Means when it forms a lump because of rolling. Dr. Sarfaraj can
I think he has dropped out.
Okay. Dr.
You see, mesoma, as Dr. Safra said, if you go by the complications, mesoma, one reason is a chronic mesh infection, and second is fibrosis. So, if it is symptomatic, initially you should try with conservative measures. And if the patient is not responding, patient has chronic, this is one of the reasons for chronic joint pain. Okay, so ultimate, if he is not responding to conservative measures, ultimately you have to think of mesh extraction, which is a very difficult surgery. I think there is some audio issue.
So, sir has logged out.
Yeah. Okay. We finish up today. Thank you.